Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health, and your moderator for today's lecture. It is my distinct pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the chat box on your screen. Please post your questions directly to the moderator. This afternoon, I have the pleasure of introducing Dr. Raul Vazquez. His presentation will be on adult spinal deformity. Dr. Vazquez is a board-certified neurosurgeon and director of the Complex Spine Neurosurgery at Baptist Health, South Florida. He specializes in the surgical treatment of complex spinal conditions, including tumors, degenerative spine diseases, spinal deformities, scoliosis, kyphoscoliosis, revisions, surgical revisions, and neurotraumas. Dr. Vazquez received his medical training at the University of Puerto Rico in San Juan, graduating summa cum laude. He completed his internship in residency in neurosurgery in the University of Florida in Gainesville, Florida. His postdoctoral training also included 2 fellowships, one in clinical research at the National Institute of Health in Bethesda, Maryland, and the other in complex spinal surgery at Vanderbilt University in Nashville, Tennessee. Prior to joining Baptist Health Neuroscience Institute, Dr. Vazquez was an assistant professor of neurosurgery at the University of Kentucky College of Medicine in Lexington, Virginia, healthcare system in Lexington, Kentucky. Dr. Vazquez served as an editorial reviewer for World Neurosurgery and Operative Neurosurgery journals. He is widely published in peer-reviewed medical journals and is an avid speaker at national and international scientific symposiums. His professional membership includes the American Association of Neurosurgical Surgeons, Congress of Neurological Surgeons, and the North American Spine Society. Dr. Vazquez is fluent in English and Spanish. Please let's all give a warm welcome to Dr. Vazquez. Dr. Vazquez, what a pleasure having you with us, and thank you so much for accepting our invitation.
Well, thank you very much for having me. It's a pleasure to talk to you guys about some of the very common conditions in the spine, and looking forward for this talk.
Thank you. Doctor, we're ready for your presentation.
All right. Good afternoon, everyone. Today I'll be talking about adult spinal deformity and some of the most common conditions that we encounter every day in our clinic and as a career in neurosurgery. I want to let you know we don't have any disclosure. The objective of this talk is to explain and talk about the overview of different spinal disorders, the anatomy, the pathophysiology. We would like to understand how is that we ended up with the final problem and pathology of adult spinal deformity. I would like to explain the different concept of scoliosis, which is very common in our population, post-laminectomy syndrome, and revision spinal surgery. I'd like to discuss about the future of spinal surgery, where we are at here at Baptist Health South Florida in terms of the new technology, incoming research outcome, and understanding the different measure and metrics that we have to better treat our patients. I'd like to start with brief case. This is something that we see in our office every day, and if it has not happened to you, it will at some point in your life. You have very good chances. This is a 44-year-old laborer that comes to your office with a 2-week history of severe lower back pain after lifting 125 pounds. This patient is a heavy smoker, no history of weight loss. He's very uncomfortable, has a lot of muscle spasm, has severe back pain and tenderness. He can move his legs, neuronormal exam. He's constantly changing positions. He said his lawyer from his work needs a copy of the note. How would you proceed? You know, this the first time this person has back pain for 2 weeks now. The answer of this is educate, you know, anti-inflammatory, temporary work modifications with avoiding lifting and avoiding injury. So now we know after evaluating the workload of many physicians, especially spine surgeons and neurosurgeons, that lower back pain has a 70% lifetime incidence. At some point in our life, we all gonna have an episode of back pain. Prevalence of about up to 30% and an incidence of 5%. Given a year, 18% of the workforce will miss 149 million work days because of back pain. 30 million office visit to the doctor. So it's the second most common cause for visiting a doctor is after common cold. Is one of the most common causes of disability in the ages of less than 45. And it has a compounding or aggregate cost of about $86 million a year, billions. So just talking a little bit about the history of spinal surgery, how we got to where we are. For centuries, for many years, spine surgery has evolved and revolve around three basic goals, which is decompressing of the nerves when we have the common in language out there in the community, you know, when you have a pinched nerve. So it was to decompress, stabilize the spine, and correction of the deformity in cases of scoliosis. Earliest dating back to the ancient Egypt, you know, there's still describe a spinal pathology like cervical spine fracture, and even before that, you know, we were talking about designing beds to stabilize the spine, doing traction for what at that time they didn't know, but it was a scoliosis. These are some of the more rudimentary measurements of straightening spine pathologies back in the days. It progresses. It's not until British surgeon Henry Klein carried out the first laminectomy in 1814. Unfortunately, the patient died 3 days after the surgery because of infection. But is when they first described the actual decompression of a pinched nerve. One of the first actual modern spinal surgery. Then an American surgeon, Dr. Smith, carried out the first successful laminectomy in Kentucky in 1828. So about 14 years later, he was able to do the same procedure on a patient that had fallen from a horse and sustained acute paralysis, couldn't move his legs. The patient again only survived the operation, but not only survived the operation, but achieved partial recovery. Then later on, several years later, Horsley resected the first spinal tumor, the first tumor from the spinal cord through a laminectomy. The history of a spinal surgery evolved very rapidly. It was not until the 70s, 80s, and 90s that then we started developing more technology. In the 50s, we did our first discectomy in the neck from an anterior approach. Then in the 60s, we started using things like the microscope to do microsurgery and introducing different technologies to take out disc from the middle of the spine in the thoracic spine. In the 70s, we already now have the technology of a CAT scan, a CT scan. Then later, 4 years later, we have MRI. And now we started understanding better the different spine pathology, diagnosing the pathology of pinched nerve, deformity, and and understanding later better the biomechanics of the spine. In the 80s, then we start developing different materials, metals, in which we can correct the spines, the scoliosis, and we start introducing more and more the concept of adult spinal deformity. In the 90s, we are making the techniques more with more finesse and security and safety in terms of using intraoperative imaging, artificial disc, and then great advances involve a critical look at the previously accepted innovations. The need for fusions was questioned in the 90s, and the need for many cervical disc surgeries was questioned. So now it's not until late 90s, early 2000s that then we start introducing the evidence-based medicine and understanding better the different spine pathology. So seeing how for many years we didn't understand a lot on the spine, a lot about scoliosis, and it's not until the last few decades that we are able to introduce many of the concepts that we know right now. The spine is a complex 3D structure. It goes from the skull base, from the base of the head, all the way down to your tailbone, to the sacrum. It protects neural elements and provides a large amount of flexibility to the trunk. As an organ in the system, in the human body, it has some biomechanics. The study of the mechanics of a living body, especially the forces of the muscle and the gravity on the skeleton, on the spinal structure. Spine regional anatomy and biomechanics are implicated in all the acute or chronic pathology that involve disc degeneration, deformity, trauma, tumor, infection, inflammatory. So when it comes to understanding spine and adult spinal deformity, we like to identify the different pathologies, either chronic or acute, because it's not only affecting the nerves, the anatomy, the bones, but also the biomechanics. Further spinal decompression with bony, ligamentous, and joints like disc and synovial removal will alter the stability of the spine and its ability to respond to stress. So what we have found more and more is that everything that we do in the spine has a consequences later on. That becomes very important in something that I'm going to mention pretty soon. So the incidence of spinal fusion has been steadily increasing in the US over the last 20 years. Not only in the US, but worldwide. I mean, even in places with different healthcare systems, the incidence of spinal fusions has increased significantly. The placement of internal spinal fixation as well as arthrodesis further altered the spine biomechanics with potential for downstream iatrogenic consequences. And that's where more and more we have identified the concept of iatrogenic adult spinal deformity. And that's the topic of my talk. How, because of all this spinal surgery, now we're doing even more spinal surgery, bigger spinal surgery, and causing what we call adult spinal deformity. This is becoming more prevalent, obviously, because people are living longer. We have an aging population. We'll present that a little bit later on a slide. Right, not only the US population, but the world population is getting older with the advances on the cardiac surgery, prevention of a stroke, treatment of a stroke, treatment of heart disease, management of diabetes. So people are living longer, and consequently, we're going to see a lot of this adult spinal deformity. In order to better understand spinal pathology with regards to their pathophysiology processes, structural effects, resulting clinical symptomatology, and ultimately management, it does require a complete understanding of the regional anatomy of the spine and its applied biomechanics. The spine is divided in 5 regions. We have the cervical spine, or commonly known as the neck area, thoracic spine between your shoulder blades and all the way down to your lumbar spine, your lower back. Then we have the sacrum and the coccyx. The cervical thoracolumbar joints is divided based on kinematics and clinical correlations. This is a macroscopic anatomy or view of the spine and the actual curvatures and appearance that the spine should have in a normal, healthy adult with no spinal pathology. There are specific problems that affect our spine. We have degenerative disc disease that cause radiculopathy, or the pinched nerve that cause radiating pain nerve down to the legs and the arms. We have spondylosis, stenosis, which can occur in both lumbar cervical, and I would add there to that slide in the thoracic as well. Spondylolisthesis, tumors, and emergencies. Now emergencies are acute fracture, dislocation, and different kind of trauma. This is an example, radiographic example. I would like on and off alternate this talk with different actual representations of the pathology. This is an MRI of the cervical spine of the neck of a patient that demonstrated a large cyst within the spinal cord. This patient presented with severe neck pain and arm pain that was radiating to the left arm. Initially, they thought it was like a pull muscle, that it was a pinched nerve. It was not until we got this MRI that we identified that it was something else. We did an MRI with contrast now, and we can see a small enhancing lesion or tumor to the right side of the spinal cord that was causing that large cyst within the spinal cord. Turned out that this was a tumor that was causing the arm pain and the neck pain, in combination with some problem that he was having with balance and like myelopathy. We did a small laminectomy, resected the spinal cord tumor, and this is the resulted MRI several months later. So it tells you that many things. This patient also has some disc herniation, disc degeneration, but the problem in this case was a spinal cord tumor. So the lumbar spine, I'm going to divide this talk a little bit into lumbar spine, which is the most prevalent and cause of adult spinal deformity. It is very important because that's where they reside on the peripheral nerves that goes and supply your legs and your bowel bladder function. The majority of the lumbar, the presentations in clinic for a patient presents with lower back pain. That's the most common presentation of problem with your spine, is including when you have a deformity or even a scoliosis. The majority of the causes of this back pain we can never identify. It's what we call idiopathic. It can be many reasons: muscular, from the arthritis, from the joints. Then it's a component, very small component, that is due to disc herniation, trauma like fracture, or degeneration like a spondylolisthesis, or it can be tumors or even infections. Okay, so as one of the most common problems that we have in our lower back, that unfortunately is going to happen to all of us. Some of us faster than others, and some of the population exaggerated or exacerbated by different situations. For example, patients with rheumatoid arthritis or patients that are chronic smokers. These kind of changes into the disc or the cushions that we have between the bony anatomy is going to happen faster, and consequently more chances that they're going to develop lower back pain. It's not necessarily a disease. It's not necessarily that you have sickness is something that is going to happen related to the age. The problem is when that happens too fast and it start pinching on the nerves. That's where we have what we call a radiculopathy or a pinched nerve. That's where we have the pathology in the younger population of a herniated disc, in the older population usually of a stenosis. Any root can become symptomatic. It could be in the neck, it could be in the lower back, and help us identify based on physical exam and radiographic studies with like MRIs or CT scans. When this happens, it's usually on one side when we have a disc herniation, when we have a bony spur that is pinching on the nerve. It can happen in the middle, and then that's where we have different pathologies like stenosis or cauda. This usually present with changes and numbness in the lower extremity, weakness, changes in the reflexes in the lumbar spine. This is how we explain the famous sciatica. It's very common to have a pathology or a compression of the sciatic nerve that can radiate all the way down to the leg and cause severe pain. And different, it could happen not only in the lumbar spine, at the level of the spine, but it can happen at the level of the piriformis. So following that understanding that we have the generation of the disc, the other kind pathology that we see is the central compression that is not necessarily related to the roots, but to the entire canal. And this is what we call a spinal stenosis. Lumbar stenosis symptoms is the classic, what we call positive shopping cart sign. Is when a patient stand up straight for a long time or walk for a long time, and the spine prompts you to lean forward to release the pressure, and then eventually even sitting down. And that's the only way that you have a relief on the amount of back pain and leg pain. That's what we call neurogenic claudication or positive lumbar cart sign. Then we have a spondylolisthesis, which is a degeneration on not only the disc, but now the joints that support the spine from behind. We call the facet joints and the pars. And it's one bone is sliding on top of the other. It's called spondylolisthesis, or what we call the slip. Usually a defect on the bone. Sometimes we are born with this, or it can be created by trauma, like repetitive trauma. Like we see this very common on gymnasts or football players. Then that leads to mechanical back pain, which we have 3 types of low back pain. There's one that is acute, very well defined. It's related to the muscle, the ligaments, herniated disc. It does improve with physical therapy. Then we have a well-defined that is chronic. This is the one that is related to the spinal stenosis, to the spondylolisthesis, and some form of chronic compression of the nerve. This is when the nerves are pinched for a long time. Then we have the poorly defined or idiopathic, which is the famous sacroiliac joint dysfunction or Facet syndrome. This is the pain that is not specific, doesn't go to your legs, doesn't go to your hips, it's primarily in the muscle of the lower back. And that's unfortunately the majority of the lower back pain that we see in clinic. So there are some risk factors for back pain, many of them. Occupational, heavy lifting. There's some psychological association to it. Patient with severe depression tends to have more back pain or discomfort. And things like obesity and smoking are extremely associated with the incident of back pain. In fact, in a weight loss regimen program, patient can have a significant improvement of back pain as well as a smoking cessation. And there's some genetic components and iatrogenic, like prior surgery, post-laminectomy syndrome, flat back syndrome, where we call the adult spinal deformity. So then we have this is a different kind of case. This is a young guy that presented with back pain after undergoing a bicycle accident. He presented with a fracture in his spine. He's healthy, and he presents with this CT scan where you can see an acute fracture on the spine in a very dangerous place because it's in the thoracic spine that can cause compression of the spinal cord, but he's having severe pain. Based on this is a burst type fracture with instability, and we even had an MRI. He underwent a thoracotomy, an anterior procedure where they removed the bone, replace it, and put an expandable cage there in the area of the fracture. His back pain improved, and then he was sent home. We'll get back to this case to explain to you a little bit of what we do here at Baptist in terms of like when it comes to revision surgery and adult spinal deformity. You'll see how this case, which appears to be simple initially, turned into an adult spinal deformity. So now talking about the deformity. Deformity or scoliosis is when your spine goes out of balance. I explained to you initially in a picture like how your spine should look like clinically and radiographically straight and keeping your head in balance in related to your feet. When your spine is twisted or have an abnormal shape, then you go out of balance, and that's what we call adult spinal deformity. It happens up to 60% in the older population. The goal of the surgery is to restore that normal alignment, that normal balance, which is predominantly dominated by the sagittal balance, which is the most important predictor of pain and disability. Deformity surgery with restoration of sagittal balance can achieve significant improvement of quality of life. Sagittal balance means your tendency to go forward or backwards, okay? So we want to restore that tendency for the patient to go forward. Adult scoliosis surgery is associated with significant morbidity, mortality, which means it is a risky operation. And if it's not done in the right setting, independent of the surgeon, it can lead to significant complications. Up to 10 to 45% happening in elderly and osteotomy cases because they don't have the same resistant capacity for this such a big surgery, or maybe they don't have the technology in surgery to make this safer. What happened after this big surgery is that also you can develop problems further above in the spine is what we call proximal junctional kyphosis. And this happened because now we're altering the biomechanics of the spine. The other problem that could happen is that your bone is too weak and doesn't heal properly, and that can lead to what we call pseudoarthrosis. The mechanism and risk factors are poorly understood. We don't know why, but it's something that we have different techniques nowadays to prevent that from happening as well. And it's related to keeping that balance, your head right on top of your hips. You can see in this radiograph on your right side how after a fusion surgery, and this is the first surgery on the left side, then it progresses to one that is a little bit bigger, but then she developed further problem right above that surgery, and then we have to keep extending the fusion all the way almost to the neck. The development of this problem, what we call proximal junctional kyphosis and pseudoarthrosis, has been associated to patient factors, the older patients, female patients with diabetes, or patients that are using chronic steroids, as smokers, or have a severe osteoporosis. There's some surgery factors like the type of osteotomies, the material that we use during surgery, the kind of metal that we use, and the amount of correction that we do to the spine. And we have to do different measurements. We have a special machines here at Baptist Hospital that we can do actually dedicated scoliosis X-rays and predict before surgery, doing different measurements to prevent this kind of pathology later on. The radiography assessment for adult spinal deformity of scoliosis most of the time involves as an MRI, a CT, or a CT myelogram to look exactly where the nerve compression or the spinal cord compression is happening, a CT scan of the lumbar spine, and this what we call a Scoliosis X-Ray, which is a 36-inch film. We can see your spine all the way from the head down to your tailbone, on front and from the side, and we can analyze your coronal sagittal balance and do different pelvic measurements. I'm not going to go into specific details on that, but we do all these measurements that you see here in this determination. We have computer and actually computer programs that can help us do this more precisely. Then we do this radiographic assessment, all these angles. We measure how your spine is conforming at the level of the thoracic spine, lumbar spine, in terms of your sagittal balance, and then your pelvic measurements. So having all this, we can predict what is the goals for the surgery, how much we have to do, and then it helps us prevent having problems later on in the future. As part of this assessment also, we do look at your bone quality. We like to see how your spine moves when you look and move back and forth. And then we do even blood work that can help us predict and prevent what we call pseudoarthrosis or non-union, which is when your bone doesn't grow properly because it doesn't have enough vitamin, or you have too much of osteoporosis. This is an example of a case of a patient that on the left side, this is how he came to me before my surgery. He had already approximately it was 10 to 11 surgeries, and this is the result of all those surgeries. We can see that his head, which you cannot see it in the left radiograph, is way forward compared to his hips, and he cannot stand up straight. He's having severe pain. So this patient, we took him on a stage part of procedure. We went on front of the spine first, and we did an L5S1A lift, and then lift the entire spine back, and then did a one-level osteotomy at the level of L3, extended the fusion, and now you can see how we were able to recreate the spine in terms of his lower back with the curvature, and the thoracic spine with a nice adequate curvature. So he now in this right radiograph, you can actually see his head, that is way backwards, and he can stand up straight. The same can happen in the level of the cervical spine. This patient had an anterior and posterior surgery many years ago, but his head was falling forward despite the surgery. You can see that he has wires and a plate in the front, and his head is sort of like falling forward. And then it was compressing, doing severe compression on the spinal cord and causing what we call myelopathy. In this case, we got a CT scan. You can see that the bone never healed properly. And then now we have to extend his fusion with rods and screws. Now you can see that the head is relatively straight and the head is supported. So, and we decompress the spinal cord as well. So this patient was feeling better. But this is a type of adult spinal deformity that in the level of the neck that we were able to treat. This is another more dramatic example, a patient that surgery that we did 6 months ago. And he unfortunately had a prior surgery from L1, from C2 down to T1. And after that surgery, he presented several months later after that surgery with his neck in a 90-degree configuration. This is what we call a shin to chest deformity, because his shin is touching his chest and he cannot lift his head up. So in this case, we have to do what we call a T1 PSO, or an osteotomy. So we literally broke the spine and the neck at the level of the base of the neck and lift his entire head up with rods and screws. And he did a great recovery. So when we talk about spinal deformity, many things plays into context, the infrastructure, location, or techniques in the operating room, and that goes anywhere from positioning, from the technology that we use. We have a very modern and technique table for positioning, and we also do have the computer navigation to put the screws to make the operation safely. There are different things technically that we can do to break the spine to bring it back to that configuration. And that's what is the bulk of what we call adult spinal deformity. It's a lot of modifying the shape of the spine at the same time that we are protecting your spinal cord and your nerves. These are some other examples of pretty severe adult spinal deformity and scoliosis after having surgery. Most of these things, patients have scoliosis, and it does get worse and exacerbated by a prior surgery. So it's what we call iatrogenic adult spinal scoliosis or deformity, because it was caused by a prior surgery or precipitated. For the most part. So in this case, this patient had a severe deformity and scoliosis, and it did require a correction of the scoliosis, like you can see on the right side. This is the same patient and picture, but from a lateral view. And you can see that we went from on a straight spine, we were able to recreate that lumbar lordosis. This is another example of adult spinal deformity with a severe scoliosis, and in which we did this surgery and we did the correction of the scoliosis. This is the same picture, but from the lateral view. Another one, this patient had two surgeries prior. Now the spine keeps bending forward, it's more unstable. These screws are in the wrong place, and then we have to replace and correct the scoliosis. So going back to that second case, so that patient had the young guy that fell from the bike. He comes back now with worsening pain. Now he presents with these X-rays, but the problem is this is a CT scan. His graft subside, which means the metal cage that they put on the front went into the other bodies that they were not broken. So now it's causing worsening, deformity, and kyphosis. Despite physical therapy, despite bracing, he kept getting worse and worse with worse back pain. And he was now not able to stand up straight because it was so bended. So now is where we call the biomechanics, understanding adult spinal deformity. We know that something failed from that prior surgery because of the different physics that we understand on these kind of fractures. And now the patient have to undergo a big revision surgery in which we have to remove that prior instrumentation and make his spine sort of like straight again. We did a lateral extracavitary approach with posterior fusion and a 360 reconstruction of the spine. This time he didn't have to do a thoracotomy. We did it all from behind via a lateral extracavitary approach. And this is the result of the surgery. We put a a humeral graft spanning 3 vertebral bodies that were already broken. And from a curved position, we were able to put him in a more straight position. And this is the picture. These are some of the techniques that we use for adult spinal deformity when we have to do a 360 reconstruction of the spine or vertebrectomy, like a lateral extracavitary approach. I'm not intending to go on the details of this technical procedure, but it's sort of like different ways that we can approach the spine. Then it's always good to understand that not everything is age or degeneration. Sometimes we can have tumors. This patient unfortunately had a metastatic prostate cancer to the spine, causing a severe fracture and pressure on the spinal cord and on the nerves. And then this is a CT scan, and then we had to do a 360 reconstruction of the spine with a cage and rods and screws. For us to predict how patients are going to do, though here at Baptist, we have a very comprehensive research projects that are based on a spine registry and outcomes. We would like to think that what we do is the right thing and everyone is good and happy, but we have to document that. We have to know how they do after all these procedures to see, right, if it's worth it in terms of quality metrics, in terms of your quality of life and satisfaction. So we have different, every surgical patient here will undergo a registry, understanding their condition before and right after the surgery, so that way we can modify our practice, and if it's something that perhaps that we can change in the operating room or before, to sort of optimize the way that you're going to do after surgery. We have throughout my career, we have many publications about the association, for example, of baseline affective disorders of depression in the rates of readmissions and after elective spine surgery, how body mass index or weight will predict how you're going to do after the surgery, how understanding the pathology of anterior cervical discectomy, in how smoking has an impact on cervical spine fusion and surgery. So all these things, even though it sounds very intuitive or predictive, but it helps us educate the patients and say, listen, if you're smoking, more likely that even if we do the best surgery in the best center, most likely there's a good chance that you might not be too happy or not do that well because of all these factors. And we can modify this before a surgery, and then patients do better. So I think the treatment of like any spine condition of adult spinal deformity is to prevent recurrence, to promote health, maintain healthy weight, regular exercise, core straightening, avoid making patient worse with medications or with surgeries that are not necessary or not the best plan, and doing some modifications in the lifestyle. In conclusion, using the physical exam is the best way to find the source of the problem. We have to be aware of the red flags, like I mentioned initially, like tumors or infections, and always manage the symptom, the patient, and to educate the patient about all these conditions. These are some other example of red flags. Like I say, when you think it's just a pinched nerve of a pull muscle and turn out that it's a big tumor causing pressure on the spinal cord and require this kind of surgery. And I think we're good at 45 minutes, and I'm open to questions. Thank you very much.
Thank you so much, Dr. Vazquez, for such an insightful presentation. I'm sure we will get some questions. Please post your questions directly into the Q&A session. You may ask your questions there and we will make sure to address them as we see them. In the meanwhile, and until we get a question, Doctor, that's quite brilliant. I have actually several questions to ask because they're asked of us when patients approach us, right, that they want to come and be treated by one of our neurosurgeons. What is the maximum age that you have seen or you have treated in your practice that will require this kind of procedure?
That's the maximum age that I've done probably a big adult spinal scoliosis correction surgery. She was probably 82.
Wow.
And that was, but it's very, I mean, like I said, we have an aging population. It's not uncommon that you have in your clinic walking a 91, a 92. There's a cutoff, right? For that, I think I do believe in, first do not harm, right? So it's one of these things that unfortunately there is a limit. I would hate to say, oh, this is the age cutoff because the performances are different. That said, the capacity when it comes to age is still relatively the same. I do see patients that see me on consultation and they have some of these pathologies, but they are 91, 92, even though they are in a very good performance. Then we have to understand that their capacity to undergo this kind of surgeries is not the same, perhaps, than a 70 or a 60. So it does take that into account. And now we are understanding a little bit more as well. The fact that the anesthesia, prolonged anesthesia in octogenarians and 90 years old it does affect it can exacerbate a neurocognitive decline. So we have to take that into account as well. Mm-hmm.
Certainly. And in the past, we always heard, scoliosis can be treated, but you have to be a pediatric patient. You cannot wait until you're an adult already with a huge hump in your back. And then on the opposite, do you treat pediatric cases or you just limit to anything above 18 years of age?
So I limit my practice just to adult. That said, like you said, a big component of the adult spinal deformity or scoliosis is patients that had adolescent idiopathic scoliosis and now they waited and they're an adult. So it's interesting. We are perhaps treating the same pathology, the same problem, but at a different age. But in terms of practice itself, I limited 18 and above. Yeah.
Yep, it's remarkable the incredible accomplishments that you guys have done in the new devices that you use, especially to fuse and to correct those misalignments in the column. There was a big issue in the past with the intravertebral cement injection, which we still see in other countries that they still use. Do we use that, and when do we limit the use of the cement for fractures of the spine?
Yeah, so we do still do a relatively amount of what now we call it kyphoplasty. Correct. Historically, I think that we started with vertebroplasty, that we would just inject the cement and that's it. Now we actually put a balloon there, inflate the balloon to create a space and reduce the fracture, and then we inject the cement. So we still do a fair amount of it in selected patients. So I think I agree. It was, and there were conflicting randomized control trials that actually questioned the efficacy of that procedure. But actually, in hindsight, I think we had a very good clinical experience selected patients for treatment of fractures with the cement. Yeah.
Okay. Once you deem a patient appropriate for a procedure such as the ones you presented, because these patients, obviously we are talking about the international patients, have to plan ahead their post-surgical intervention. What is the time frame that you always tell your patients locally, domestically, or from abroad that they need to count with in order for them to also count with rehab after the surgery?
Mm-hmm. So in general, if it's one of these big surgeries, I would say that they will be in the hospital for about a week, with rehabilitation, pain management, and then for another 2 weeks in an inpatient rehab. That would be the acute rehabilitation of 3 weeks. Then after that, they probably the overall recovery, and that could be at home, is about 6 to 8 weeks, about 2 months almost. But for that acute planning, I would say probably 3 weeks, depending on the extension of the surgery, right? Like I do a lot of minimal invasive surgery as well, or ambulatory surgery. Then the time frame is different. Those are, it could be a matter of a few days, or stay around for a week so that we can see you in a week to do a wound check. So it's if you're traveling, but it all depends on the extension, how extensive the surgery is.
Fantastic. Yeah, we do get a lot of questions in regards to, look, I want to have a surgery, except that I don't know how long I'm going to stay in Miami for. And but we can always, we have worked out with the orthopedic patients as well, that once they get to a stabilized time in their post-surgical treatment, we can always continue in country by you providing a plan of care or plan of therapy that they can follow in their own home country.
Yeah.
So that will be extremely important. Anastasia is saying, I have back pain. Well, Anastasia, it's easy. You already met Dr. Raul Vazquez. It's a matter of just coming to visit Baptist and we'll take care of you. Yeah. Listen, Dr. Vazquez, what a pleasure having you here with us today. And thank you so much for allowing us time during your busy schedule. I want to thank you on behalf of our international team, and especially our in-country managers who are all present tonight with us. If you have additional questions for Dr. Vazquez, please make sure to send them to bhiwebinars@baptisthealth.net. That is bhiwebinars@baptisthealth.net. We'll make sure to provide you with an answer as soon as Dr. Vazquez receives your questions. We look forward to seeing you in our next neurosurgical lecture series, which is scheduled for July 21 of this year, of course. Thank you once again. Please stay safe, get vaccinated when you can, and use your mask. We'll see you soon. Thank you, Dr. Vazquez.
All right. Thank you, guys. Thank you very much.